I think we are continuing to learn about MRD assessment in terms of what the best technique is, when it should be incorporated, how we might be able to use it in future study design. And some of the abstracts that were presented today were really looking at, in some cases, single center, single institution experiences. In some cases, they were comparing one technique versus the other. So right now, the majority of MRD testing is being done either with next generation flow cytometry or next generation sequencing. And there's still a great debate in the field as to whether one is superior to the other. That has not been answered, but I think what the data are showing thus far that in general there's very good concordance between the two methods. There's always a lot of details involved in terms of what the sensitivity was, how long the cells sat on a bench somewhere, et cetera. But certainly these single center institution studies are demonstrating the feasibility of doing these types of approaches. There's also increasing data about the importance of durability of MRD negativity. So in the past, some of the studies really just focused on achievement of MRD negativity at one time point. And while that does predict outcomes, it's becoming increasingly clear that really what is most important is having sustained MRD negativity. And we're starting to get some data out of some of the abstracts presented today about whether it's 6 months durability, 12 months, et cetera. And all of that is going to play into how we design clinical trials in the future and what new endpoints we might involve in the future. In some cases, it is a matter of consistency. In some cases, it might have to do with whether or not there was a diagnostic sample that was present and whether the sequencing could be performed successfully. So in the case of the next generation sequencing, in some cases with flow cytometry, it's something that many centers can more readily do on their own. And so both techniques are dependent on the quality of the bone marrow aspirate sample, so you have that intrinsic problem that's inherent to both techniques. And really until we move to perhaps a more readily available sources such as peripheral blood, I think many of these discussions are going to be about whether or not the technique was able to analyze, for example, a first pull bone marrow specimen as opposed to getting a very hemodilute specimen later on, and therefore the sensitivity is diminished. Right now, in terms of routine clinical practice, MRD assessment should not be used to make any clinical trial or clinical decisions outside the context of a clinical trial. At this point in time, although we know that achievement of MRD negativity is in general good, we don't know what to do with that information in terms of making treatment decisions. So we do not have data at this point saying that achievement of one-time MRD negativity means that you can stop your therapy or change your therapy. Alternatively, we also don't know that if you convert from MRD negative to MRD positive, that means that you should automatically switch what you're doing. So really what's important moving forward are designing clinical trials that ask those types of decision-making questions so that eventually we can translate that into routine clinical practice.